So welcome everyone. Can you please confirm that you can hear me? Okay. There you go. Thank you so much. My name is Daria. Thank you for joining us today for our POCUS Bytes webinar. I will be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or chat box for any comments you have throughout the webinar. Today, topic is ectopic pregnancy, and our speaker is Rawan Alsukairi. Rawan joined the Society of Diagnostic Medical Sonography in 2016. The following year, she graduated from Rochester Institute of Technology in Rochester, New York, with 2 bachelor degrees, one in biomedical science and the other in diagnostic medical sonography. In 2017, Rawan obtained her OBGYN and general abdomen credentials from ARDMS. In 2018, Rawan returned to Saudi Arabia, where she became a licensed sonography specialist with Saudi Commission for Health Specialty. Rawan worked in the Middle East as a sonographer from 2018 until recent time. In 2021, she published her first textbook in Arabic, focused on the role of ultrasound during pregnancy, and was volunteering her expertise with us. She volunteered a couple of times in 2021 and presented some webinar series. You can find those on the website as well. At the same time, she was promoted to lead the ultrasound training program for a year. And since 2021, she has been active volunteer and participated as a speaker in several events. And most recently, Rawan is selected as one of the alumni speakers for the RIT 2024 Annual Women's Leadership Summit themed Owning Your Voice. Thank you again, Rawan, for sharing your expertise with us. And I will now share the screen with her presentations.
Hello, everyone. My name is Rawan Alsukairi. I am ARDMS and General Abdomen and OBGYN, and it's such an honor to be today presenting for POCUS, and specifically the topic related to pregnancy. What if it's too early to call it an ectopic, and how timing matters is something very important for sonographers and beginners to familiarize with, to be more comfortable. So the objectives of today's presentation are defining ectopic pregnancy, familiarize with the sonographic appearance of ectopic versus corpus luteum, review interesting cases, familiarize with Spiegelberg criteria of ectopic, and understand the correlation of beta for the diagnosis. So ectopic pregnancy is the most common cause of a pregnancy-related death in the first trimester. Sonography is the imaging method of choice when it comes to evaluating women with suspected ectopic pregnancy. 95% of all ectopic pregnancy occurs within the fallopian tube. The remaining 5% of ectopic are non-tubal in origin and will including locations such as the abdomen, the cervix, ovary, and or within the hysterectomy scar after procedure. So ovarian ectopic pregnancy is one of the rarest form of non-tubal ectopic pregnancies, has an incidence rate of approximately 1% to 6 of all diagnosed ectopic. Result from secondary implantation in the ovary or from failure of follicular extortion. So some risk factors will be all the many earlier studies linked ovarian ectopic pregnancy to the use of the intracontraceptive device. More recent researches has refuted this assertion, and there are other risk factors will include history of endometriosis, ovulation induction, advanced maternal age. So clinical presentations are mild to moderate pelvic pain, vaginal bleeding, abnormal beta HCG levels, and palpable adnexal mass. So the differential diagnosis of ovarian ectopic would be a corpus luteum cyst, hemorrhagic ovarian cyst, appendicitis, or a tubal ectopic, and an early or failed intrauterine pregnancy. So what is the Spiegelberg criteria of ectopic pregnancy? It's historically used for intraoperative diagnosis. You will see intact fallopian tube in the affected site. Fetal sac must occupy the position of the ovary in the affected side. Ovary connected to the uterus by ovarian ligament, and ovarian tissue must be located in the sac wall, which is confirmed by histopathology reports. So here is an example of corpus luteum versus ectopic. In the right side of the screen, you can see a regular corpus luteum cyst in the right ovary, whereas in the other side of the screen in here, you can see a very thick ring-like hyperechoic structures, and this is the one that's the typical sonographic appearance of ectopic. So in sonography, the echogenicity of ectopic pregnancy is increased when compared to the ovarian stroma, whereas a corpus luteum is usually less echogenic. Also, another studies indicated that the stroma at the case of ovarian ectopic is thicker than with the fallopian ectopic pregnancy. So the role of Doppler and ring of fire sign. The use of Doppler to distinguish between an ovarian ectopic pregnancy and corpus luteum cyst is unreliable. They can each display what we call it the ring of fire sign, as both the ectopic ring and the wall of corpus luteum can both have significant vascularity within their peripheries. Relying on the sonographic sign will misguide you then. So what's the role of spectral Doppler? The use of color Doppler, pulse wave Doppler, is likewise of limited value. Studies have shown that there is no significant difference between the peak systolic velocity of an ectopic pregnancy compared to that one of corpus luteum. So how can we help? When early pregnant show up to rule out ectopic and we only see ring of fire, at this point, you would slow down, and perhaps this might be just too soon to start seeing a sac, whether intrauterine or extrauterine, and we would want to have a correlation with beta HCG levels and see how it goes. So, case of heterotopic pregnancy. 36 years old, Gravida 7, parity 5015, presented to the emergency department with severe lower abdominal pain, vaginal spotting. Previously, she was diagnosed with ectopic and was given a methotrexate. Her CBC was stable and beta HCG was decreasing. So, past medical history, she had anemia during pregnancy, ectopic pregnancy, history of C-section twice, and she is a status post abdominoplasty in 2019. So here is the beta in several days, and it shows you how it dropped down from 2600 into 1265. So that's what we saw in sonography. You can see a sac within the endometrium in the correct location, still very small at this period of time. And then in the left adnexa, there was this structure with very thick hyperechoic periphery. And here is a more clear image of the finding in the left adnexa, suspected ectopic. So this was the left ovary, and adjacent to it, you can see the ectopic. And then we had to do a color Doppler to see the ring of fire And within the ectopic itself, that is located immediately adjacent to left ovary, within its lumen, you can see the yolk sac. So this can allow you also to better differentiate between corpus luteum and ectopic. So definitely, you know, this is the ectopic. So she came again for follow-up to the emergency department, and still again, here is the finding, the ectopic, and that's the ovary. And then the next day, it appeared more like mass. Here is a power doubler of the same finding of the patient. It was measuring 1.71 by 1.59 by 1.19 centimeter. She came up again, and the third time she came for a follow-up, it looks way different. Left ovary, and here is the mass. So the left ovary was blended with so much of blood. And here is the endometrium. And remember how the sac within the endometrium was so small and how it looked like earlier, 2 days ago. And then in 3 days, it just became very bigger in size with so much of internal echoes. And that's a very abnormal looking for normal pregnancy. So here is a color doubler of the finding. Very increased hyperemic flow within the periphery, the ectopic adjacent to the ovary. And that's the gestational sac within the endometrium containing the internal echoes. And minimal free fluid represented in the posterior cul-de-sac. And here you see the fluid adjacent to the ectopic in the adnexal area. So then, as you can see, here is the ectopic. You can see surrounding the whole ectopic pregnancy, there is so much of blood came in within the follow-up that wasn't seen before, which is a sign of ruptured ectopic. And then a spectral Doppler evaluation was made to ensure there is arterial flow coming in. And here you can appreciate a better look of how you can see the blood within the periphery of the whole ectopic itself, diagnosed into plane and sagittal and transverse, and the free fluid in cul-de-sac. So those within a few couples of days, it's progress enough. The free fluid wasn't seen at the really beginning, but then in 3 days it ruptured. The patient started having that blood around the ectopic and so much of a fluid. And here how it looked like, and the whole thing became blinded together for their 4th follow-up. So again, to sum up and to remind you of what we found from day 1 into day 3 or 4. Day 1, there was the hyperechoic periphery of ectopic that looked like a ring containing a yolk sac. And then in day 3, it's blinded with a ruptured fluid and became as a mass. And day 4, so you can appreciate and see how thicker it became and how bigger in size, blinded with the blood, the whole ectopic became later on. So prior to the operation of this patient, patient informed with the proposed plan, given consent for laparotomy and left salpingectomy. So the risk and benefit and complications as well, and the treatment options were explained all to the patient. So then the procedure took place. Patient was taken to the operation room with fully catheter, and correct identification of patient was made. Procedure verified as unilateral salpingectomy at time, and timeout was held, and above info were confirmed. So prophylactic antibiotic 2 grams of IVF were given to the patient, and metronidazole were given as well. So general anesthesia given and was adequate. Patient was prepared in the usual sterile manner. Incision was made and carried down through the subcutaneous tissue to the fascia. Fascia incision was made and extended transversely. So the fascia was separated from the underlying rectus tissue superiorly and inferiorly. The peritoneum was identified and entered. Peritoneal incision was extended longitudinally, 1 liter of blood and blood clot noted and removed. Left fallopian tube slightly enlarged and blood clot noted surrounding the fimbrial end. So the uterine outline and bilateral ovaries were normal. Left salpingectomy was done and incision was closed. Hemostasis was observed. So here is another patient came in with what you can see in right ovary, most likely corpus luteum, as the hyperechogenicity is less and it's less thick in comparing to any ectopic you could see. So the cystic structure within the right adnexa, which is most likely the corpus luteum, was measuring 1.3 by 0.9 by 1.2 centimeter. And here is a color Doppler obtained and a spectral Doppler to represent the arterial flow with RI 0.53 centimeter. And then a power Doppler was obtained as well. Here is the endometrium, is very thick, measuring 0.8 without any presentation of any intrauterine sac at that point. So what happened in situation like this? We would report it to the radiologist and let them know that we couldn't see any intrauterine sac, neither extrauterine. If in both adnexa we couldn't see any, and allow correlation with beta and give it few times. So another case, gravida 2 para 1 woman in her late 30s. She was scheduled for ultrasound due to light vaginal bleeding. She was currently 7 weeks and 5 days by her last known menstrual period, and by medical history significant for second infertility. She was being treated with ovulation induction by means of clomiphene citrate 50 milligram. No history of endometriosis, sexually transmitted disease, or pelvic inflammatory disease, nor had she any previous gynecological surgery. So hysterosalpingogram reported a normal uterus and patient fallopian tube bilaterally was normal. The patient didn't have any current lab values, with her most recent beta HCG level being some 2 weeks prior. At that time, it was 186.8, corresponding to a gestational age of 4 to 5 weeks of a pregnancy. Then ultrasound performed revealed an empty uterus. The left ovary contained a simple corpus luteum cyst, as well as 1.6 centimeter by 1.4 hyperechoic mass with thick wall and an echoic center. No yolk sac or fetal ball were seen. There was a second simple cystic structure located in the left adnexa, measuring 2.1 centimeter, consistent with clot. So here is the ultrasound finding, and again seen in color Doppler. You can see the hyperechoic structure, peripheral, very thick wall adjacent to the cystic structure of left ovary. So that's a corpus luteum, and this ended up being the ectopic. So lab workout, this information taken along with the sonographic finding was highly suggestive of an ectopic pregnancy for this case. Laboratory work completed after her sonogram, and the beta was 2044, demonstrating abnormal rays over the past 2 weeks. So embryo and ectopics, a live embryo is seen in less than 10% of sonographically detected ectopics. So suspected ectopic, the exact location of the suspected ectopic couldn't be confirmed with certainty. The patient denied any pelvic pain, dizziness, or shoulder pain. Her vital signs were stable with no palpable adnexal mass, and the patient was counseled in the suspected pregnancy. So the course of action, as she was in no acute distress, it was decided that she would follow up in 2 days after to give her additional time and then see the beta levels before determining her course of management. So the ectopic precautions were reviewed with the patient, and 2 days later, the patient presented to the emergency room complaining of significant pelvic pain and increased vaginal bleeding. Her beta HCG level had dropped to 1235. Physical exam revealed tenderness in the left adnexa and palpable mass. And then transvaginal pelvic examination was ordered and completed. And here is the finding in her second visit to the emergency department. Scan revealed a moderate amount of a free fluid in the pelvic cavity and a large complex mass in the left adnexa containing septations. The previously described echo left ovarian mass was no longer visualized. The patient was taken for a laparotomy for suspected ruptured left ectopic pregnancy, as we saw in the really first case I showed you earlier. So during surgery, 300 cubic centimeter of clot and dark blood were removed. What appeared to be ruptured hemorrhagic cyst was noted in the left ovary with active bleeding. A simple left ovarian cyst as well as left paratubal cyst were also noted and drained, and the left fallopian tube was otherwise unremarkable. Subsequent histopathological analysis of the left ovarian mass revealed immature placental villi and clot, confirming the presence of an ovarian ectopic pregnancy. So laparoscopy is considered the gold standard in the definitive diagnosis and the treatment for ovarian ectopic pregnancy, and conservation of the ovary is possible in many cases. So even with direct visualization during surgery, an ovarian pregnancy can still be mistaken for hemorrhagic cyst, as the surgeon did in this case, and histological confirmation may be required to confirm the diagnosis. So in the case presented, the diagnosis of an ectopic pregnancy was presumed because of abnormal serum beta HCG, empty uterus, and suspicious sonographic adnexal finding. So again, Spiegelberg criteria, at the time of surgery, all the 4 Spiegelberg criteria were met. The ipsilateral tube was normal and separate from the ovary. The pregnancy occupied normal position of the ovary. The ovary was attached to the uterus by ovarian ligament, and there was pathological confirmation of a placental tissue attached to the ovarian stroma. So the conclusion of this case was, although it is very challenging to confirm the presence of ectopic with the ovary, the presence of hyperechoic thick-walled mass in the ovary, and with the absence of an identifiable intrauterine pregnancy, along with the suspicious clinical symptom and serum beta HCG levels, should prompt the clinicians to consider ovarian ectopic pregnancy as a potential diagnosis. So here is another case presented of 40 years old woman came to the emergency complaining of abdominal cramping and spotting. The patient reported seeing a fertility specialist and had undergone in vitro fertilization, IVF. She had a positive pregnancy test and estimated 5 weeks, 4 days of gestation, and the patient reported gravida 1 and para 0. So in sonography, within the right ovary, there is hemorrhagic cyst measuring 2.2 centimeter and a 2 centimeter simple cyst. So you can see here left ovary, cystic structure, and another structure with thick stroma. The left ovary also contained a palpable hemorrhagic cyst measuring 1.9, and within the left adnexa is the appearance to be the gestational sac, as we saw in here. So uterine fibroid as well were presented on her, and the largest was 2.2 centimeter by 1.9. The gestational sac contained a yolk sac and measured 6.9 centimeter, which correspond to a gestational age of 5 weeks, 3 days. There was no evidence of an intrauterine pregnancy, and after considering the beta HCG serum result of 3500 and the ultrasound finding, the diagnosis of ectopic pregnancy was made. So the treatment for her was immediately following the sonogram, the patient was treated with a single intramuscular injection of methotrexate and asked to return to serial beta HCG test. So post methotrexate injection, after 6 days of the injection, the beta level rose to 6400. So in the 12th and the 16th day, the beta level fell to 4,400 and 2,100 respectively. So in the 19th day following the initial sonogram and the methotrexate administration to her, endovaginal was performed. It showed normal appearing endometrium measuring 3 millimeter. So the previously noted uterine fibroid appeared unchanged. Small probable hemorrhagic cysts were again found within each ovary. Adjacent to the left ovary, the ectopic was noted as before, and the gestational sac contained an embryonic wall in addition to the yolk sac previously seen. No heart tone was detected. The crown rump length of 32 millimeters suggested a gestational age of 6 weeks and 0 days. So here is the sonographic finding, and here you can see in the left adnexa, the gestational sac and the fetal ball that look like a piece of rice measured. CRL was 0.32 centimeter, which correspond to 6 weeks and 0 days. So in day 25 post the methotrexate injection, the beta level fell further to 1,285. At that time, the attending obstetricians performed a left-sided salpingectomy based on the preoperative diagnosis. of a persistent left ectopic pregnancy. A 7.2 centimeter segment of the left fallopian tube, including the fimbriated end at the left ovary, was removed and sent to the pathology. As far as a prognosis, the patient had a good surgical outcome and no follow-up beta serum test or sonogram were ordered any further. So IVF and ectopic, women who undergo IVF have a much higher rate of ectopic pregnancy than general population. About 4% to 5% of IVF patients presented with an ectopic pregnancy, approximately twice the rate for women who haven't received IVF because of many risk factors, such as increased age and smoking. The use of superovulating agent in IVF alter the tubal mobility. Risk of retrograde migration, where embryo may enter and implant in the fallopian tube after being transferred into the uterus. So beta HCG and early pregnancy. In abnormal pregnancies, the beta HCG level double approximately every 48 hours. The beta HCG value will not double at the expected rate in case of ectopic because of the size of fallopian tube. Growth of an ectopic pregnancy is restricted and the beta will fail to double correspondingly. So an empty uterus can also will indicate either a missed abortion or a pregnancy that is too early to be visualized sonographically. So here is where we must slow down and be very, very careful with the impression we make to our note or that we report to the radiologist, because time is gonna matter and you don't wanna be calling a normal intrauterine pregnancy ectopic soon enough, and she could have her chance of carrying a normal healthy pregnancy. So beta HCG, correlating beta HCG level with the sonographic finding is essential for the accurate diagnosis of ectopic pregnancy. Heterotopic pregnancy, it is also important to realize that the presence of an intrauterine pregnancy does not necessarily exclude any chances of ectopic coming along at the same time. Heterotopic pregnancy occur when gestational sac in the uterus and an ectopic pregnancy coexist together at once. So here in sonography, you can see ectopic and the ovary, the ectopic adjacent to the ovary and one side of the adnexa. So methotrexate in a treatment, when beta HCG level is above 5,000, the average time for an ectopic pregnancy to resolve with a single dose of methotrexate is 32 days. However, a recent research suggests physicians can predict whether an ectopic will resolve after a single dose of methotrexate by following the trend of beta HCG level for the first 4 days. If there is a rise in beta level within the first 4 days, there is only 42% chance that the ectopic pregnancy will resolve in its own, compared with an 88% chance with a decrease in beta during the time interval. So here is the sonographic appearance of ovary, and adjacent to it you can see the ectopic pregnancy. It's immediately adjacent to it. You see the stroma is very hyperechoic and very thick in comparison to the wall of a simple cyst or the wall of corpus luteum. And you can see also, aside of that, exterior to the finding, free fluid in the adnexa. You would want also to ask the patient at that point where the pain, at which side is she having or experiencing the pain, and usually and majority of the time you will be finding that the area of pain is correlated to where you see the ectopic pregnancy. So here is corpus luteum cyst. As I said before, its wall is way thinner than the wall of ectopic pregnancy, although both of them are going to show you the ring of fire, increase hyperemic flow within the periphery. So you don't want the color doubler to misguide you, and you would want to really be careful with the other sonographic appearance. So corpus luteum cyst and ring of fire, still all of those are corpus luteum cyst and showing the typical ring of fire sonographic appearance. So when should it regress? It should regress between 16 to 18 weeks of gestation. So here is a case of abortion. Clinically, 28 years old gravida 2 para 1 represented to the emergency with suspected abortion. No beta HCG was provided by the time the ultrasound was ordered. So here, there is intrauterine sac was measuring 1.83 centimeter with very thick stromal appearance. And here in another plane, it was measuring in transverse 1.3 by 0.9 centimeter. And the adnexa, you can see those cystic structures and this internal echo within the lumen of the cystic structure itself. It have arranged pattern that we were not sure what it is, and until we discussed this with the radiologist, and those appear to be a very prominent to adjacent follicle. The patient was asked if was going under any follicular stimulation and denied using any. And here, within the next follow-up, there is a representation of hypoechoic structure which appear as subchorionic hematoma adjacent to the sac-like structure within the endometrium. This hypoechoic subchorionic hematoma was measuring 1.4 by 0.9 by 1.6 centimeter. And then in the right adnexa, a color Doppler image was obtained. And this is a corpus luteum, and within the right ovary, two dominant follicle, just because they are very adjacent to each other, you can just really see their wall in very defined way in comparison to usual. So a color and spectral Doppler image was obtained for the corpus luteum cyst, and the RI was 0.58. So the radiologist report was left ovary normal in size, right ovary enlarged, estimated volume of 26.2 milliliter. There are two dominant follicle and corpus luteum. So the impression was intrauterine gestational sac consistent of 5 weeks and 5 days. No evidence of sizable yolk sac, no evidence of fetal ball, without benefit of a quantitative beta HCG and last menstrual period. As by the time the ultrasound was done, there was no data for beta HCG in file, and the patient wasn't even sure of her first day of last period. So the radiologist reported that without the quantitative beta, it is difficult to confirm non-viable of pregnancy. So the recommendation made by the radiologist was quantitative beta is to be requested since none is available at the time of the examination. So a few days after the ultrasound scan, beta was ordered twice. It measured first 31,271.5. After 2 days, it measured around 29,500, which dropped. And lab results were explained to the patients as the value regressed. Patient needed to seek help in obstetrics. So the follow-up, no new update. And common pitfall when it comes to ruling out ectopic pregnancy are finding that can mimic ectopic are corpus luteum cyst as explained, para-ovarian cyst, such as the dominant follicle, dermoid cyst, or bowel can obscure ectopic pregnancy.
All right. Thank you so much, Rawan, for sharing the presentation. Rawan did prepare some quiz questions for you. And while we're doing those, feel free to submit any questions you may have about presentation or overall topic, and we will share it with Rawan. So give me just a second. I'll pull it up, her quiz questions. And you'll also see a question pop up on your screen, so you can answer the question. Let's go to the first one.
Which of the following is an ectopic pregnancy?
Okay. Feel free to answer in the full question. So I'll give you maybe a minute to respond. And again, feel free to submit your questions for Rawan in the Q&A box. Okay, I see there's some people are answering. We have about 40% people answer the question, so let's test your knowledge. Okay, we're at about 1 minute and 50% answers, so giving you another 10 seconds. So if you're watching, feel free to respond to the first question. Okay, so let's end the poll. I'm going to share the results and let's see what's the correct question is. All right.
So the correct answer is C. B is the ectopic, where we said those are the two dominant follicles adjacent to each others. Is this an ectopic pregnancy?
Okay, let's go for the second question. And the question is, if you see on the screen, is this an ectopic pregnancy? You see the image on the screen, answer yes or no. Yeah, I see about 40% of people who are still watching are responding. So feel free to submit your answer now. We will go another maybe 15 to 20 seconds. Yes. And if you can submit your answers via chat, I'm sorry, not chat, via poll. Not via chat. Okay, so let's see the results.
It's not ectopic because you can see that it has the very thinner periphery comparing to ectopic, and this is a typical appearance of corpus luteum.
Okay.
What is your course
The next question is, what's your course of action if your findings were these two for a case of ruling out ectopic pregnancy? So you should see two pictures on your screen. Feel free to respond. Right, about 40% people who are watching responded, so I'll give another 15 seconds. Okay. All right, let's see the results.
Of action, if you find those diagnoses, you end up with endometrium like this, and that's what you see in the adnexa. So the correct answer is you have two correct answers in those. Of course, the first one is wrong. You shouldn't call it an ectopic. You will be describing your finding to the reporting doctor to allow correlation with beta and further follow-up. And it's also not wrong at all to ask a colleague to try either see your images from the screen or even go and have a look inside the scanning room with you to see perhaps there is anything. That is also a correct answer. So take home point, beta HCG is a must for diagnosing and ruling out ectopic pregnancy. You cannot rely on sono finding only without the clinical correlation. In normal pregnancy, beta should increase by at least 66% in 48 hours. Site of patient pain in lots of the time is correlated to the site of ectopic. So here are the references I have used, and you are welcome to ask any question or email them to me. Thank you so much.
All right, thank you so much, Rawan, for sharing your presentation with us. Thank you, everyone, for joining us today. Before you leave, I have launched another poll for you. If you can help answer that question, it definitely helps us plan future webinars and future topics for you to present. And again, thank you so much for taking the time today. The webinar was recorded, so if you would like to rewatch it, it will be available next week. So we take about 1 week to put out the recording, and you'll get a link with to download the recording. I'm sorry, to watch the recording on the website. So feel free to email us with any questions, or if you haven't submitted questions to Rawan, put them in a Q&A box and she will reach back out to answer your questions again. Thank you so much. Have a wonderful day or whatever you are. We'll see you next time. Thank you.